rambling. But yeah, so that's the breakdown for exam one. Overall, the average is actually pretty good. Usually, like, that's what people typically kind of score. That's what the average kind of looks like for exam one. Exam two is kind of a bit the same. One person was like 1 point away from having completely aced it, so well done. I didn't end up dropping any questions just because I didn't see anything like really egregious. So this one here, what are malignant neoplasms arising from connective tissue called? So this one here, just kind of a little bit of Latin from the lecture there. Melanomas, that's going to be related to the skin. Fibromas, that's going to be some very fibrous stuff. So that's connective tissue. Sarcomas, sarcomas are also connective tissue. Carcinomas, these are malignant epithelial. So we're between B and C. So we're going to go back to the question here. The key word is going to be malignant. So if the keyword is being malignant, it's got to be sarcomas because fibromas is benign, while sarcomas is malignant. Okay. Questions on this one? I think this might have been a case of people reading too quickly. All right. How does vasodilation from inflammation directly aid in fighting bacterial infection? So we got vasodilation going on here. So we vasodilate. Well, pain that comes from bradykinins and prostaglandins, so that one's out. Increases fluid to the area, that's true. Allows for diapedesis. That's increased capillary permeability, not vasodilation, so we're going to rule that one out. Increased fluids will trigger mast cells to release histamine. Well, we have two that are talking about increasing fluids there. How do mast cells release histamine? How do you get a water balloon to release water? You have to like pop it, like damage it, right? So therefore, B is going to be the better answer there. Questions on this one? The cells most directly responsible for destroying a virus. So B plasma cells, those make the antibodies. Macrophages, they eat stuff. T helper cells, they coordinate. T cytotoxic, they kill virus/cancer cells. So again, correct me if this is not the way you guys were thinking here. Macrophages, if a virus enters a macrophage, it's just going to replicate inside of a macrophage. T helper cells, they coordinate. They tell other cells to kill the virus. They're not directly responsible for it, so that's out. Okay. B plasma cells make the antibodies, which then go and destroy the virus. So the antibodies are directly destroying the virus. The B plasma cells are only making them. Therefore, best answer here would be T cytotoxic. Questions on this one? Okay. All right. Patient who is severely immunocompromised due to AIDS catches the common cold. What kind of immunity should be prioritized in said patient? So a couple of different ways you can kind of go about this. Natural, so you're biologically exposing them to anything. Do you want to give this person more viruses? Right? Probably not. Natural passive. Does anybody remember the only example of natural passive that we had?
It was breastfeeding, wasn't it?
Yeah. You going to breastfeed your patient? I sincerely hope not.
That might get a little awkward.
Yeah. So between artificial active and artificial passive, what's the difference?
Artificial active is like getting a vaccine,
Mhm.
and then passive is the injection of antibodies from a donor.
Nice. Yeah. So this person already has the cold. Would they benefit from getting a vaccine? If you have COVID, would it help to get the vaccine? Probably not. A little too late. Yeah. What's another reason why artificial passive would be the best answer here?
It's like giving the answers.
Yeah, it's like giving the answers. This person is severely immunocompromised. They don't have time to build that memory. They don't have time to learn. Therefore, artificial passive. Questions on this one? Cool. All right. I think this one was definitely a case of reading too quickly. Which cell would have the most chromosomes? Triploid means 3 sets, which means how many chromosomes?
Is it 69?
Trisomy 3 chromosome 21s. So that means they have 46 plus that extra ones, 47. Haploids. So your gametes have how many chromosomes?
23.
23. Perfect. And Klinefelters. So that's XXY, 47. Did people kind of read too quickly on that one?
Did some of us have different questions? Because I don't remember some of these unless I just like.
Yeah. So what happens is I wrote like 60 different questions and it pulls 35 randomly. So sometimes you got these questions, sometimes you didn't. So that's why I'm saying, like, if you want to meet to talk about your exam, I'd be more than happy to, just because some of these questions might not apply. Cool. All right. And that's the end of exam 1. Okay. Overall, I think you guys did really well. You did really well. So I would say definitely keep it up here. Exam 2 is the neurophys, neuropatho, and then fluid electrolytes and pH balance. Neurophys and neuropatho is not too bad just because you need to know kind of just surface level stuff. Fluid and electrolytes, that's when it gets a little bit more complicated. And that'll be Monday's lecture. Okay. Uh-oh. Sorry. Let's see. So your quiz on Monday will be just neuropatho. Okay, just neuropatho. All right, so let's see. We left off on acute pain, I believe, yeah? Cool. All right, so this first part of lecture is going to go by pretty quickly. It's because the second and third part are a little bit more important, so I'm going to make sure we slow down for those. But this stuff, again, very superficial. Okay, so acute pain is going to alert you if there's something wrong with your body. It can be transient, i.e. it can come and go. Okay. So let me ask you guys, acute pain, is this physiologic or pathologic?
Physiologic.
I agree. This is a type of physiologic pain. Why? Why would acute pain be helpful?
It allows us to know that there's something going on, like something
Yeah.
bad happening.
You got it. You got it. Okay, so this is actually pretty helpful. In fact, it's the only kind of helpful pain. There are a couple different types of acute pain. It just depends on where they're at. So acute somatic, if you guys remember, your somatic nervous system controls what? Your somatic nervous system will control what?
Your skeletal muscles.
Skeletal muscle. So acute somatic is everything in the periphery, skin, joints, muscles. Perfect. Okay. Large A's. So thankfully you guys already seen this before. Large A's, they detect pain that is sharp and well localized. Versus small C's, dull, aching, throbbing, radiating, burning, soreness. It's poorly localized. So in your somatic nervous system, in your periphery, you can feel both sharp and dull. Makes sense. Your visceral, so think about your viscera, these are your internal organs. They only have small C's. They only have small C's. So if you think about a stomach ache, right, it's because you only have small C's there. Sometimes this pain can radiate or be referred. So referred pain, there's a definition here, a different definition that I kind of like a little bit better. Referred pain is pain in an unrelated area. Okay. So I want you to think, for example, like a heart attack. When somebody suffers a heart attack, what usually also ends up aching? Heartache. Heart attack. Sorry. When somebody suffers a heart attack, what usually ends up also being in pain?
Sometimes their jaw.
Their jaw, yeah. Or I was thinking like the left arm.
Yeah,
You guys have heard of that, right? It kind of goes down. Why? Why is the left arm hurting when the heart is the problem? So this chart kind of explains it. Let me say again, you do not need to memorize this chart, but just understanding, hey, here's your heart attack. This area down the left arm shares a common nerve. So if you experience here, your brain has a hard time telling where the pain actually is, so everything just starts hurting. That's the idea of referred pain. Another example, has anyone ever drank so much alcohol that their right shoulder started hurting?
Yeah,
Serious? Oh, that's not good.
once upon a time.
That's not good. So if somebody complains like, oh, my right shoulder is sore, it's been tight, no matter what I do, it doesn't relieve it. If this pain doesn't go away, so Lita, don't freak out, but if this pain doesn't go away, that can actually be signs of liver cirrhosis. So this is, referred pain can actually be very helpful to kind of give you a clue on what's going on inside of the body. Something else might be going on. Okay. So that's just the main takeaway point. You don't need to memorize this chart. Good, good. I'm glad it was never again. All right, so now we move to chronic pain. Now, chronic pain, different definitions. For me, it's anywhere between 3 to 6 months of persistent pain or intermittent pain. Okay. Now, I kind of mentioned to you guys, like I have chronic back pain. Okay, some days are great, some days not so much. So mine is intermittent. Now, what's kind of interesting is it can cause significant psychological changes. So I want you to imagine if somebody is in a constant state of pain, what is their demeanor going to be? What happens when you try to, interact with them? What are they like?
Pretty cranky.
Yeah, irritable. Absolutely. What else?
Sometimes depression.
Yeah. And with depression, I'm going to add like isolation. Okay, take for example, like, I don't know, my friends want to go extreme free diving. I don't know, extreme bungee jumping. I'm like, my back says no. So, I can't really sometimes do some of the things that they do. Sure. Another one that's kind of interesting, they become very impulsive. They don't think things through. What's interesting though, you see these psychological changes, but you do not see physiological changes. So i.e., let's imagine that I get stabbed in the hand. What should happen to my vitals? How will my vitals change?
Your heart rate's going to go up. Your blood pressure's going to go up unless you're losing a lot of blood.
Yeah. What about respiratory rate?
It's going to go up. Everything's going to.
Yeah. Perfect. So with acute pain, we can see that in the vitals. With chronic pain, though, the baseline vitals reset, where pain is the new normal. So again, I have chronic back pain. If you took my vitals, I'd be, in theory, standard blood pressure, standard heart rate, within range, respiratory rate, etc. So question for you then, as future nurses, how do you measure chronic pain? What objective assessment can you do to determine if somebody's in chronic pain?
You can't really.
You can't really. So this brings up the idea that chronic pain is the most difficult to assess, because you just have to take my word for it that I'm in pain. So let me say assess/diagnose. Okay. So question then, chronic pain, is this physio or patho?
Patho.
This is a form of pathological pain. There is no benefit for me to be continuously in pain. Okay. All right, so now we're talking about neuropathic pain. So patho again means disease. So these are diseases of the nervous system. What's kind of interesting about neuropathic pain, you can see pain without stimulation. So take, for example, anybody like to sit on their in their chair with one of their legs underneath them? Sit cross-legged. Okay, if you sit like that for, let's say, an hour, what happens when you stand up?
Your leg's asleep.
Your leg's asleep. So what does it feel like when it's waking up?
Tingly and angry.
Yeah, tingly. I kind of like pins and needles, right? Can feel like the shooting pain, the shock. So because you sat on your leg, there was no blood. That's why it's waking up. Here, their nerves are dying. Their nerves are dying, and the nerve screaming out produces this pain. Okay, so usually the signs of like, this is going to indicate nerve damage. Now, I'm not saying sitting in your chair with your leg underneath you is going to cause nerve damage. I'm saying this is what they feel constantly. Okay. So peripheral neuropathic pain. So this is in the periphery. This can be DM or GB, i.e. diabetes mellitus and Guillain. Sorry, this is a GI. Guillain-Barré. Or it can be central. Again, remember, central refers to the brain or spinal cord. Okay. These two types of pain that are central neuropathic, allodynia and hyperalgesia. Just rough definitions here. Allodynia is pain to non-painful stimuli. Okay. So think about the shirt that you're wearing. It's comfortable, yeah? Hopefully, that's why you chose it. Somebody with allodynia, they put on a shirt and it feels like their skin is on fire. Their brain and their spinal cord are misinterpreting this non-painful stimuli as pain. Okay. Hyperalgesia, this is increased sensitivity to pain. Usually due to prolonged opiate use. Usually. So I want you to imagine, again, for my back pain, imagine if I have to take some sort of opiate, some sort of pain medication. If I've been taking opiates for about a year to manage my pain, my body realizes this is not good. I need to feel things. I need to be able to interact with the environment. So it turns up the sensitivity. So therefore, are the opiates still working? No, so then I have to take more, okay? Alexis, I'll pick on you, sorry. This is an example of what happens to your big toe with this hypersensitivity because you didn't feel anything before. Your body's like, this is not good. I need to be aware of my environment. So it grows excess nerves. So not always from opiate use, it can be from trauma too. So question for you, neuropathic pain, physio or patho?
Pathological?
Absolutely. This is not helpful. Okay. So again, the only type of pain that is helpful is acute pain. Everything else is not good, not helpful. Okay. So now we're going to take a sharp left here, talk about fever. You see what I'm saying? Like this is a bunch of random topics. So all you need to worry about the fever is that it's controlled by your hypothalamus. Hypothalamus. You don't need to worry about the other 2 points here. So fevers are generally actually kind of good because it increases the reactions, i.e. it increases your metabolism. So when you have a fever, that actually helps increase your metabolism. Therefore, you're making more cells, your cells are breaking more things down. It's awesome. So fever, is this a physio or pathological response?
Physiological?
Yeah, it's helpful. However, if we lose control of our thermostat, now it crosses into pathological. So when we have an elevation of the body temperature without a hypothalamic set point. So fevers, let's say it's like about, I don't know, like 100-ish, right? Someone comes in with 100-degree body temperature, you probably understand that it's a fever, yeah? What if somebody comes in with 104? 105, and their body temperature keeps going up? That is hyperthermia. Would you agree that's pretty pathological? Right? Because now our temperature is so high that we're basically cooking ourselves alive. Not good. Okay. However, small amounts of hyperthermia can be therapeutic. What's something that can give you hyperthermia for a short period of time?
Exercise?
Exercise, yeah. I was thinking like, saunas, hot tubs, they're great. Again, it's only for a short period of time. So that's the therapeutic use. Accidental, so this is what I was talking about with a stroke or head trauma. So it could be that someone falls and hits their head and then you take vitals and they're at 104. Makes no sense. What's going on? They might have damaged their hypothalamus. Okay. All right, so hyperthermia was bad. Now we cross into malignant hyperthermia. Anytime you see mal in the medical field, what does mal mean?
Bad.
Yeah, so this is like super bad hyperthermia. Okay, I don't know why, but this shows up in every single one of your nursing classes. So just heads up. Malignant hyperthermia is a rare inherited disorder. So this is actually a genetic condition here. Normally, no problem. Most of the time you are asymptomatic. Most people who have this don't even know that they have it. Unless you have reason to go looking in your genes, you would never know, it would never bother you. What sets this off is when they inhale anesthesia. So if you inhale anesthesia, what happens is that your body kind of freaks out a little bit. So let me kind of trace this out here. If you inhale anesthesia, your body thinks that you're actually suffocating because you have less oxygen. So I'm going to say body misinterprets as decreased oxygen. So again, your body thinks you're suffocating. Your body thinks that you're drowning. So what happens is your body starts freaking out. Your muscles start contracting. They're trying to save you. Okay. Like, I don't know, kind of dark here, but drowning is not a graceful way to go. Okay. The muscles will increase activity. Okay, again, just because they think that you're drowning. So that's going to produce, guess what? A lot of heat. Okay, so that explains the elevated temperature. But when muscles start working, what byproduct do they release?
Lactic acid.
They produce lactic acid. Yeah. Now the problem is lactic acid is an acid. You start producing so much lactic acid that this starts interfering with your bodily systems. You have no way to get rid of it. We'll talk about acid-base balance on Monday. With this excess lactic acid, what ends up happening is you increase heart rate. The idea there is, if we can't get rid of this acid, let's circulate it as fast as we can to minimize exposure to the tissues. Okay, so kind of walking you through this, you go in for, I don't know, a root canal, you inhale some anesthesia, you're sitting there, and all of a sudden your patient starts sweating. That's weird. And you see their muscles twitching. Okay. You check their vitals, heart rate laying down is 120, 140, 150, 180, 200. What's going to happen if your heart rate beats so fast? What happens if heart rate is like, I don't know, 210?
You'll have a heart attack.
Yeah, that's the problem with malignant hyperthermia, is it leads to cardiac arrest. So if anybody in your family has a poor reaction to inhaled anesthesia, that's something you should probably investigate before you start inhaling anesthesia. Also, it's something to kind of ask patients, like, again, you would never know unless you're going in for a procedure, right? So let's think about this. You're a nurse, your patient starts exhibiting this elevated heart rate and this super high temperature. What do you do? Just thinking out loud, what do you do?
Cool them down.
Yeah, so we're going to throw ice packs on them, right? We're going to try to submerge them. Then we're also going to try to neutralize that acid by giving them bicarbonate. Very good. Different people have different onsets. Some people, this will onset within like 10 minutes. Other people, this will onset a few hours later. It's kind of weird. All right, on the other side, hypothermia. You don't need to memorize this temperature here. Just the issue is if your body temperature gets too cold, ice crystals form. Okay. I want you to imagine, is it football season yet? I don't know. I don't watch sports. Okay. If it's football season, let's just say you got your friends coming over to watch the game. You run out to the pack, or you run out to the store and you get a 6-pack of beer, but you know, you're fancy. You gotta get the ones in the glass bottles. They're your friends. So you throw your glass bottles in the freezer. You guys have a great time and you forget about them. What happens the next day when you open up your freezer? What do you find?
A bunch of busted glass.
Yeah, a bunch of busted glass and frozen beer everywhere. Why? Why did the beer bottles explode in the freezer?
Because when ice forms, it expands.
Yeah.
So it made too much like stuff to stay inside the bottle.
Yeah, you got it. You got it. In hypothermia, that's what happens to your cells. That's frostbite. I want you to imagine those beer bottles being your individual cells. When you cool the water too much, your cells explode. So, can we heal frostbite? Not really. Can you heal a broken beer bottle? Not really. So, just here, hypothermia, the big issue is that ice crystals form. What's kind of interesting, when things get cold, it does slow metabolism. In fact, it actually increases blood viscosity and slows blood. Why? When would you want to slow down blood flow? When would you want to slow cellular metabolism? Think about in your job as a future nurse. When would it be helpful to slow blood flow?
When somebody's septic?
When somebody's septic, or I was thinking more like surgery. So we actually use hypothermia a lot of times during surgery. Has anyone ever been in an OR? How did it feel? Nice little ambient Florida temperature in there.
No, it's freezing.
It's freezing. It's freezing because we're trying to induce hypothermia. Sometimes we might even add ice packs around the patient to chill them. Why? If we slow metabolism, that means your cells aren't functioning as quickly. That also means they aren't dying as quickly. So we also slow cell death. Hey, that's kind of helpful during a surgery, yes, when you need to make cuts and XYZ. Another example, I'm mowing my lawn with flip-flops. I slip, toe comes off. What do I need to do with my toe immediately?
Put it in ice.
Put it on ice. That's what they tell you. Why should you put it on ice? It slows cellular death. So hopefully they can reattach it. Okay. Accidental hypothermia, don't worry about it. It's like if little Timmy falls through the lake. Fun fact, does anybody know what the longest surviving record of somebody surviving after falling under ice? It's something stupid like 4 hours. 9-year-old girl fell through the ice for like 4 hours and she survived with no major brain deficits. It's stupid. I'll look up the article during break. It's crazy. Sleep. How sweet, sweet sleep. Okay, so all you need to worry about sleep, you have non-REM sleep. There are 3 stages. Sorry, I lied. 4 stages. 4 stages. And REM sleep. What does REM stand for?
Rapid eye movement.
Movement.
Yeah, rapid eye
Bing.
movement. Absolutely. So your eyes are kind of jumping all over the place. This is also known as paradoxical sleep, i.e., your brain is just as active as if you were awake. So if you did a brain scan of someone being conscious next to a brain scan of someone during REM sleep, they would look almost identical. So when you're dreaming, your eyes are darting, it's like you're awake. So question then, what is the deepest stage of sleep?
Isn't it like right before REM sleep happens?
You got it. Non-REM stage 4. Absolutely. This non-REM stage 4 is so deep. If you smack somebody in the patellar tendon, they won't kick. But they will kick during all the other different cycles, including REM. Okay. So stage 4 non-REM sleep is the deepest sleep. So this is your brain when you're in non-REM. This is your brain on REM. Again, super active. It looks like you are conscious. Okay. Paradoxical sleep. Sleep disorders, insomnia. Like I'm not really going to get into these ones. This is more kind of like mental health. Yeah. Because the reason why I'm going to talk about sleep apnea a little bit later with respiratory stuff, so that's why I'm like, right now. Narcolepsy. So if somebody has narcolepsy, they have hypersomnia. Hyper meaning excessive. Somnia is kind of like sleepiness. Okay. That's all you need to know about narcolepsy because we don't know why. This is just a theory right now. But I mean, for crying out loud, we don't even know why we sleep. Sleep is a weird area of research. All right, visual dysfunctions. So first up, we got strabismus. Strabismus here is a cross-eyed appearance. Did you guys already talk about strabismus in health assessment? No, not yet. I think it'll come up in a little bit then. To emphasize, this is not lazy eye. Okay. The difference, if you're curious, lazy eye is an issue with visual acuity. So if somebody has lazy eye, it means like their left eye is weaker than their right. Okay. Here, it's just that one eye is going to deviate. One eye deviates from central focus. Okay. So strabismus, one eye is kind of pointed a different direction. It can see just fine. Sometimes you can see strabismus combined with lazy eye, where the eye that's deviating is a little lazy, or it can't focus as well. Nystagmus, this is going to be involuntary shaking. Okay. Has anybody ever seen nystagmus? It's kind of cool. Yeah, it's kind of cool, right? So my younger sister, she has nystagmus. When she turns, her eyes will actually kind of like ring horizontally. You get a horizontal ring or a vertical ring. What's kind of interesting about nystagmus is that there is no change in vision. Okay. So even though their eyes are ringing, their vision isn't shaking. Their eyes are moving, but their vision is stable. The only way that they really know that their eyes are ringing is because they can feel it. Okay. Different things can set it off. So sometimes being a high emotional state can do it. My sister, for hers to set it off, she has to turn too quickly. So I kind of make fun of her, like she's like Zoolander. She can't turn left unless her eyes start ringing. So here is strabismus, again, this crossed-eyed appearance. With strabismus, yeah, we have an eye that's looking elsewhere, but it's still strong enough to actually maintain a clear picture. So that's why I'm saying be careful. Strabismus is not lazy-eyed, but you can call it cross-eyed. Glaucoma. Oh, my glaucoma is acting up. Glaucoma is increased intraocular pressure. So you have increased fluid in the eye. You don't need to write this down, but this is the second leading cause of blindness. Again, you don't need to write this down, but I'm just saying, hey, if you don't fix this glaucoma, you can go blind. Okay. Two types of glaucomas. You have open angle and closed angle. With the open angle, this is going to lead to a gradual loss of visual acuity. Visual acuity. So basically the vision is going to get duller and duller. Okay. And I'm going to show you guys a picture that can help tell you the difference here. Closed angle. This is considered a medical emergency. Medical emergency. This is going to be a sudden clouding of vision. So the vision just suddenly becomes kind of cloudy, almost like cataracts, but it's going to happen within a few hours. Okay. If this happens, a closed angle glaucoma, they need medical attention now or they're going to be blind. Okay. So let me kind of show you the different pictures here. With an open angle, so open over here. So what happens is you have fluid in your eye, yeah? Glaucoma is a buildup of this pressure. This fluid isn't draining properly. This humor needs to flow from underneath your iris and then drain into these holes. The issue with an open angle is that these drain holes get clogged. So we're going to slowly build up pressure over time. That's why you have this gradual loss, okay? For a closed angle, what happens is the iris completely collapses. So the iris actually completely collapses and blocks off the lens. So now the fluid can't leave actually, that means if fluid can't pass under the iris. Okay. So if you think about this iris collapsing here, you notice how this is a smaller space? That's why we see this large rise in pressure very quickly. So large increase of pressure, and it happens very quickly. In health assessment, you're going to get more into assessing like if it's peripheral vision loss or if it's clouding, which one it can mean. For me, you just need to know what they are. Okay. All right, other visual dysfunctions here. So first up, we got myopia, nearsightedness. This is when the focal point is in front of the retina. Hyperopia, farsightedness. The focal point is behind the retina. Astigmatism. This is where a person has multiple focal points. Okay. So, and there's a picture coming up that'll kind of actually give you a better idea of this. So What we ideally want to be able to do is that's your retina. Light comes in, your lens focuses it right onto that retina. Myopia, notice you are in front of the retina. Hyperopia, you are behind the retina. Okay, so that's actually what I'm kind of like talking about there with that focal point. For astigmatism, it can vary for different people. It can be an issue with the cornea or an issue with the lens. Either way, there's these divots that cause light to be dispersed into multiple focal points. Therefore, it kind of causes an overall blurry picture. Okay. So with astigmatism, let's say I have astigmatism and I get contacts. Can I give my contact to somebody else who has astigmatism? No, no, because their divots are different from mine. Okay. All right. The ear, I think is fascinating, but we're going to kind of roll past it a little bit. The one structure you need to worry about is the semicircular canals. Your semicircular canals, they provide feedback regarding balance. And I'm going to say orientation. Not like sexual orientation. I'm talking about your body's orientation. Okay. So if you take a look, these canals, these rings are filled with fluid. Okay, they're filled with fluid. So this tells you if you're standing right side up or not. Okay. You ever see that prank where somebody sits in an office chair and you start spinning them in a circle? As you spin them in a circle, all of that fluid gets pushed to the outer edges of the semicircular canal. So that way, when you stop spinning the chair and they stand up and they start walking, what do you guys notice about the way they walk?
They're like weeble wobbles are all over the place.
Yeah, they're like all over the place. And do you ever see them drift one direction? It's because all of that fluid got pushed over here and the body's like, okay, that's normal. That's our new normal. Okay. So take, for example, things like vertigo can be issues with too much fluid or misinterpreting the fluid in those canals. Therefore, it feels like you're falling when you're not. Okay. Another example, you guys have heard of the myth, right? If you get buried in an avalanche, how do you know which way is up?
You don't.
You kind of do. You kind of do. Anyone ever
I
been
wouldn't.
upside? Anybody ever been upside down for a long period of time? What happens to your head? How does your head feel?
A lot of pressure, I feel like.
There's a lot of pressure because all of that fluid's coming down. That's what's going to tell you that you're upside down at your semicircular canals. The myth about being buried by an avalanche is that you need to spit to know which way is down. You'll know if you're upside down. Gravity only works one way. Okay. Yeah. So just tying this in, you don't need to make any note of it, but hey, look, your vestibular cochlear nerve, cranial nerve number 8, it's tied directly to your semicircular canals. That's why it's hearing and balance. All right. We're going to skip Meniere's disease. Ear infections. So just a little bit of like tying or connecting the dots here. Otitis externa. So ot refers to the ear. Itis, this is an infection of the outer ear. This mostly affects adults. Otitis media. Does anyone know what media means? It means middle. So like media res means to begin in the middle. This is mostly often going to happen in pediatric patients. So question then is why? Why are kids more likely to get middle ear infections versus outer ear infections?
Is it because the tubules haven't like straightened out yet to drain, right?
Part of it is the ears, i.e. the ear canals in a pediatric patient are shorter. So you as an adult, you have a longer ear canal that prevents infections of the middle ear. So if you were to get an ear infection, thankfully it's going to be usually outer. All right, we'll skip past this one here. Skip past this one. All right, so that is the first part of the lecture. We will take a little break here, say like 10 minutes ish. Yeah, we'll go 10 minutes and then we'll jump into the next parts. Okay, so 9:15 we'll pick back up again. I'll be running around, but if you guys have questions, feel free to throw them into chat. Oop. All right. Cool. So now we're going to be getting to more kind of stuff that's more applicable, I guess, to you guys here. A little bit more direct, I guess. And this is going to be a tie into some of the stuff you guys actually just covered in health assessment as well. All right, so consciousness. Consciousness is defined by the RAS, or the reticular activating system. What this is a series of filters. Okay, a series of filters. So I want you to think about right now, you're hearing my voice, you're seeing my notes here. When's the last time you thought about the bottom of your foot? Is it cold? Itchy? What I'm getting at is I just changed your RAS. I just changed that filter for what allows you to be conscious of and not. Okay. So that's all the RAS is your brain filtering information that's important and what isn't. Right. So all of these things can change arousal, but this is going to be more for health assessment, not focusing on it here. Okay, this slide, this is going to show up in MedSurg 1, but basically you guys know you shine the light in somebody's eyeball, what should happen to their pupil? Bright light.
Constrict.
Yeah, it should pupillary constrict, right? Those are reflexes indicating different parts of the brain. Okay, one of the ways to tell if somebody has a concussion or head injury, paramedics, feel free to jump in on this. If you roll up and you see a car accident and you see somebody with unequal pupils, i.e. one's dilated, one's pinpoint, that can be signs of head trauma. Okay, don't need to worry about this for now. Just saying, like, hey, your pupils can tell you what's going on in the brain. All right, so this is a different test that we can also do to determine brain function. I'm going to zoom in, and then we can, so you can actually kind of see a little bit better. Okay, so what's going on right now? Your patient is laying down supine, so they're on their back, they're looking up, and there's like a gold star above them. Okay, you tell them, hey, keep looking at this star. You turn the head and notice both eyes should accommodate, both eyes should be able to focus on that point. You turn the head the other way. Again, both eyes are keeping focus there. How would you describe that reflex then? If both eyes are able to focus on that star despite being turned?
I would say the reflexes are intact.
Yeah, I'm going to do the unmentionable sin here and say that these reflexes are normal. I know you're not supposed to use normal in the medical field. This is just a little bit easier. Okay. All right. So different patient, you tell them to look up. You turn their head. One eye is able to focus on the star, but the other one isn't. How would you describe that reflex? Don't overthink it. What's the opposite of normal?
It's abnormal. They're not fully
Yahtzee.
intact.
I would say that's pretty abnormal if they're only able to focus with one eye, yeah? All right. Now, patient C, you're telling them to look up at the star. You turn their head, no eyes. Neither of them are able to focus on the star in any direction. What would you say about that reflex? Another word for not there?
Absent.
Beautiful. Okay. So pretty straightforward on that one there. So this is a test that you can do on patients who are in a coma or probably in a comatose state. You can actually try this at home. Hey, Thanksgiving's coming up. You're going to have lots of family around. Great little nursing school test here. What you end up doing is you get a syringe, no needle, but just a syringe, and you fill it with ice water. You plunge this ice water into their ear. Imagine that you are this patient and someone shot ice water into your ear canal. What's your reaction?
I'm not gonna like that.
Yeah, what the hell, man? Right? They're looking at what the hell's going on? Absolutely. Now, you plunge ice water into their ear canal, and one of those eyes just slowly drifts the opposite direction. How would you classify that?
Abnormal.
Yeah, that's kind of weird. Okay. Third option, you plunge ice water into their ear, no reaction. This one's going to be absent. Okay. So this is a test you can do on patients, again, who are in a coma. If they have no reaction, if there's an absence of reflexes, that might indicate cerebral or brain death. Okay. All right, so now we're going to get into abnormal posturing. What ends up happening is if you touch this patient or you kind of do the external sternal rub, they will adopt these various poses. These poses can tell you what's going on. Okay, so you do need to be familiar with these. We're going to come back to this slide because it's a good review slide. Okay, the two poses are decorticate and decerebrate. The way I kind of remember it, decorticate, you're holding your core. Think about like if you're trying to do a sit-up or a crunch, you're holding your core, decorticate, okay? Decorticate, the area is a little bit gray here, but I'm trying to simplify things. So this is how I'll kind of be describing and testing you on it. Decorticate is going to indicate damage above the brainstem. Okay. Again, just side note here, I am grossly approximating this. Sometimes people can have damage to the upper brainstem and still show decorticate posturing. On my exams, my quizzes, I'm just drawing a line at the brainstem. Okay. For decerebrate, that's going to indicate damage to the brainstem. Ooh. So talking about decorticate, again, they are holding their core. What do you guys notice? What's this patient doing?
Her legs are turned inward.
Yep, the legs are kind of internally flexed. Okay, what else? What's going on with the arms? How would you describe that?
I don't know. They're like oddly contorted, grabbing her abdomen.
I was just going to say flexion. Okay, so the thing about these different positions, it's the arms that are going to tell them apart. Both of them are going to have internal flexion of the ankles. So really you want to look at the arms to tell these apart. Okay, so decorticate, we see flexion of the arms. Again, this is going to indicate damage above the brain stem. Particularly in a structure called the midbrain. Okay. And then here, notice your symptoms will be contralateral. Contralateral, what does contralateral mean?
Opposite side.
Opposite, yeah. Okay. So notice this patient right here, both arms are flexed. So what does that tell you about the midbrain? Where's the damage to the midbrain if both arms are flexed?
Both sides?
Both sides, absolutely. For example, if I asked you a question about a patient who is in decorticate posturing with their right arm flexed, where's the damage? If just their right arm is flexed.
The left side of the brain.
The left midbrain. Yeah, exactly. Okay. Decerebrate, therefore, notice the arms are extended. Okay, so really just look at the arms. The feet are kind of ish. They're not a good tall tale kind of thing. Okay, so decerebrate again indicates damage to the brain stem. Okay, and it has a worse prognosis than decorticate. This means decerebrate posturing is worse than decorticate. The likelihood of recovering from decerebrate is less than decorticate. Why? Why is decerebrate so much worse than decorticate?
Because it's direct damage to the brainstem.
Yep, and what does the brainstem do?
Controls vital reflexes.
Absolutely. So vital reflexes may be, I'm going to say at risk. You can say also say compromised. That's totally fine. And these symptoms are ipsilateral. So ipsilateral therefore means
Is it the same side?
okay. Patient has their right arm extended in a decerebrate posture. Right arm extended. Where is the damage?
The right side of the brainstem.
Right side of the brainstem. Perfect. Okay. So we're going to review this here just because, hey, you're probably going to get questions on this. So going back up to this slide here, again, this is just a nice little review slide. Person A, what posture would you describe person A? What posture are they in?
Decorticate.
Decorticate. Okay. Both arms are flexed, I agree. Now, if person A is in decorticate, what areas are most likely damaged?
Both sides above the brainstem.
Yeah, so left and right. Left and right. That didn't work. Damn it. Sorry. Left and right midbrain. I agree. Person B, what position are they in?
Decerebrate.
Decerebrate. And that's going to indicate damage to the left and right brainstem. Okay. Now, person C is going to be more like an exam question where I say patient C, their right arm is flexed and their left arm is extended. So let's say right arm is flexed. That indicates, again, just talking about the right arm, that indicates damage where?
The
To the left side.
of
Left side of what?
the midbrain.
Midbrain. And the left arm is extended. Therefore, that's indicating damage where?
Left side of the brainstem.
Left brainstem, I agree. So that's what I might describe. Patient's right arm is flexed and their left arm is extended, or I say patient has a lesion that goes from the left midbrain to the left brain stem, what posture would the nurse expect? So it can go either way on that. What I want to emphasize though, I will not have conflicting positions. Okay, so for example, again, this is not going to be given, right? If I say damage to the right midbrain and left brainstem. So this is a situation which I will not give you, because at this point, would the left arm be straight or would it be flexed? Kind of depends. So that's just a test taking tip when you guys are taking the exam and you're like, both of these are describing the same arm. Chances are that's not the right answer. Okay, so the answer should be clear. There shouldn't be conflicting positions. You good? Okay, so total brain death, exactly as it sounds. Brain can no longer maintain internal homeostasis. Okay, there is a flat EEG. So an EEG, this measures electrical brain activity. Total brain death comes from no electrical activity. Okay, so the brain's not firing. If we were to keep this person alive, what would they need?
Everything, all the life support.
Yeah, everything, all of the life support, agreed. Because the brain is completely dead, would you see reflexes?
No.
Nope, exactly. Okay. Cerebral death, on the other hand, is the death of everything except the brainstem and usually the cerebellum. So this person, because their brainstem is intact, do they need life support? No, this is what we kind of think of as that vegetative coma, that vegetative state. Okay. They may or may not have reflexes, it just kind of depends on what's going on. Pro tip, the last sense to go is hearing. Patients have gone into vegetative comas and then woken up 5-10 years later and sued the entire medical team for all of the trash talking that they've been doing while this patient was in a vegetative state. You don't know who's listening and who's remembering. So just because someone's in a vegetative coma, just assume they can hear you. But also on the flip side, some patients who were in a vegetative coma, they are so thankful that like people didn't give up on them and that they treated them like they were still there. Okay. So just, hey, hearing's the last thing to go. Please don't slip up. Okay. This can be kind of related to locked-in syndrome. Has anybody ever heard of locked-in syndrome? This is like my medical nightmare.
You can like think and respond in your head, but you can't like do anything.
So this can happen when the anesthesiologist just fucks up just right, where they give you enough anesthesia to paralyze you, but not to put you under. So you're still conscious.
It happened to my dad when he was getting a skin graft done.
Oh God. No. Okay, so locked-in syndrome, you are awake, you are aware, but you are trapped in your body and you can feel everything.
So
Okay.
there's electrical activity going on in cerebral death, though?
Yes, there is.
Okay.
Yes, there is. Okay. So, and that actually kind of relates to what I recommend here. Locked in syndrome, absolutely, absolutely terrifying because you're going to feel, hear, and experience everything and can't scream. So terrifying thing, locked in syndrome used to happen pretty often, like give or take 10 to 14% of procedures. What? Nowadays, this is my recommendation. If you or a loved one or a patient is going in for a pretty serious surgery, ask for an EEG. They're going to put a brain net on your brain, so that way when you go under, they can monitor your brain activity. If the surgeon is about to make an incision and we see a spike in brain activity, hey, guess what? Jim's actually awake. Stop the surgery, regroup. So just again, pro tip, ask for brain monitoring before you go for any major thing. Okay.
Isn't there a condition too that some people have where they have a higher tolerance to anesthetics? So they sometimes can wake up in surgery because nobody's aware of the fact that they have such a high tolerance to it.
Absolutely. Absolutely. So I'm going to pick on poor redheads. Redheads, notorious for being terrible with anesthesia. Sometimes they don't even know, like sometimes the anesthesia has no effect on them. Other things, so it can be genetic, but it also can be like life. Take, for example, if I'm a heroin addict in recovery. Okay, so that means I've dealt with opiates all of my, for a long period of time. My metabolism of opiates is faster than the average person. Absolutely, that can lead to that too. So thankfully, anesthesiology is not our scope unless that's where you want to go. But yeah, just crazy stuff. Okay. This one we'll say leave for mental health. All right, dysphagia or aphasia. Heads up, in this class, you can use them interchangeably. I disagree with it, but you can. I refer to it as dysphagia just because it makes more grammatical sense. So what is phasia? We'll start with that. What is phasia?
Speech.
Speech. So I like dysphagia because it is abnormal speech. Okay. Speech. Okay. So you guys have actually talked about this in health assessment. I believe it was a pre-recorded lecture. Yes. Okay. You guys all see that pre-recorded lecture within the videos? No, it's okay. I got them too. I had these videos first, just saying. Lindsay went and took my videos. So just saying, dysphagia, aphasia, not a disease. It is a symptom. What would cause somebody to have abnormal speech all of a sudden?
Damage to the speech centers in the brain.
Yeah, I'm going to say like stroke. Or what we're going to call them is a CVA. CVA. Okay. So there are a few different types of dysphagia. Expressive and receptive dysphagia, I typically kind of stick with those. What I actually kind of prefer more though, with expressive dysphagia, that's known as Broca's dysphagia. Okay. The reason why I like Broca's dysphagia a little bit better, because it indicates damage to Broca's area. Indicates damage to Broca's area. Okay. Broca's area is responsible for the motor unit of speech. So in terms of symptoms, let me say there is how do I describe it? There is understanding. They understand language, but they just have difficulty finding the words. So there might be a little bit of a stutter There can be a lot of pauses, but they understand. They understand when you talk to them and they understand what they're saying. On the other side, receptive dysphagia is known as Wernicke's dysphagia. Okay. Again, I like Wernicke's dysphagia because that indicates damage to Wernicke's area. Wernicke's area, this is where we actually process language. This is where we actually can form proper sentence structures. So if I have receptive dysphagia or Wernicke's dysphagia, there is poor comprehension of language. And they kind of speak in fluent gibberish. They speak in fluent gibberish. And finally, global dysphagia. This is usually a loss of speech and understanding. Because with global dysphagia, that's damage to Broca's area and Wernicke's. Okay. So with working with patients with dysphagia or these difficulties with speech or language, what's kind of interesting is speech and writing are two different processes. So they might have an inability to talk to you, but they can write things down. You'll actually see some older people running around these memory units with cell phones because they're going to type out their message to you. Another interesting kind of thing that you can work around here is music. Music is a global process. So some people who lose the ability to talk might be able to sing lyrics out to convey what's going on. Brain is so interesting. Okay. So let me kind of show you these videos here. Again, Lindsay has them in their pre-recording, but they were mine first. So I'm going to show them. Okay. So let me make sure I show sound.
Can you tell us your name?
Mike Caputo.
And Mike, when was your stroke?
I was 7 years ago,
Okay.
and
what did you used to do?
worked Autodesk, sales, and
So what do you guys notice about Mike Caputo here? What's his understanding of language?
He understands everything she's asking.
Yeah. And he understands what he's saying too. Do you guys see how he's having some difficulty sometimes finding the words because he knows those aren't the right words? Okay. The next part is absolutely heartwarming. If anybody caught this in your first watch through.
worldwide, and very good. Yeah.
Okay. And who are you looking at over there when you turn your
That's
head?
my wife.
Okay. And why is she helping you to talk?
Anybody catch that? Who's that? Who you're talking to? How quickly did he find the word wife? Dude, Mike Caputo has found true love. It's fucking out there, y'all. Like, that's just so sweet. So yeah, there's more to it, but I figure you guys probably got the idea, right? So that's Broca's, understands language. It's just difficulty producing it. Wernicke's, this is going to be poor language understanding and fluent gibberish.
Hi, Byron. How are you?
I'm happy. Are you pretty? You look good.
What are you doing today?
We stayed with the water over here at the moment and talked with the people for them over there. They're diving for them at the moment. They'll save in the moment. He'll have water very soon for him. With luck for him.
So we're on a cruise and we're about to
We
get to
will
Juneau.
store it right here and they'll save their hands right there for them.
And what were we just doing with the iPad?
Right at the moment, they don't show a darn thing.
With the iPad that we were doing.
From-
Like here?
I'd like my change for me and change hands for me.
So what do you guys think of Byron?
He has poor comprehension and poor speech as well.
Yeah, I mean, he's forming words just fine, but do they make sense?
No,
Does it
it's
seem like he's
gibberish.
understanding what questions are being asked of him? Now, here's the interesting thing. If he's talking gibberish to us, does he understand us? I don't know. But if you notice, like, this guy's happy. This guy's happy. So even if he's hearing gibberish, like, he's still cool, man. He's still cool as a clam. So I don't know. It's kind of interesting. And again, sometimes if this is your population, like, I would love to work with old people. That's like my jam. I love old people. Writing can still be intact, which is crazy to me. Okay, so hopefully that kind of helps you guys see Broca's versus Wernicke's, expressive versus receptive dysphasias. Okay. So just illustrating here, the two areas that we were talking about, Broca's area is for speech. It's like the motor for speech. And Wernicke's area, that's going to be for kind of understanding. And Lord, I just made it worse. Understanding language. That's what I'm trying to write. So question, which side of the brain would you find Wernicke's and Broca's area? Which side of the brain would that be on? Would those be on?
Based off of this diagram, it looks like the left side.
Exactly, because the left hemisphere is responsible for
Language.
and logic. Yep, you got it. All right, dementia. So dementia kind of has a broad definition because there's a lot of different things that go into dementia, but really it's this idea of progressive failure of multiple cerebral functions. So it's this irreversible loss of multiple cognitive functions. And it can, vary on what they end up losing. They can lose orientation, i.e., they don't know where they are, who they are, what's going on, what year. They can lose short-term, long-term. They can lose speech. They can lose written. They can become impulsive. With dementia, if I have dementia and I lose my short-term memory, will I ever get that back? No. And this is what's kind of heartbreaking about dementia is this slow decline that you were watching happen in real time. Okay. All right, seizures. So seizures are basically sudden bursts or excessive discharge of your cortical neurons. So I think of seizures as this excessive burst of electricity in the brain. Okay. So seizures are this sudden burst of electricity in your brain. There are different types of seizures. One type is called a convulsion. Now be careful. A lot of people use seizures and convulsions interchangeably, and that's not actually correct. Okay, a convulsion is a type of seizures, which we'll talk about. A convulsion, that's the typical tonic-clonic, so that jerking kind of seizure that people are familiar with. Epilepsy. If somebody has epilepsy or epileptic seizures, these are going to be multiple seizures due to some unknown cause. Okay, this is another thing that general media gets wrong. Epileptic seizures are not due to flashing lights. That is a test that we do to determine if it's a photosensitive seizure. Okay, so somebody has epilepsy, they've had seizures, but we just don't know why yet. Make sense? So if somebody has a seizure for some unknown cause, this one of the weird things that we don't think about, your license gets revoked. Okay. One of my friends, he's wrapping up med school. He was starting med school in Florida. He had an epileptic seizure. The state of Florida revoked his driver's license for a year. He could not reapply for a whole year. And even after that year, he had to go for another year free of any seizures before he could reapply. Does that become inconvenient for anyone? Yeah. Okay, so these are the different types of seizures. A partial seizure is only part of the brain. Only part of the brain is actually having this burst of electricity. So let's assume patient has a partial seizure on the left hemisphere. What evidence would we have as nurses? How do we know that it's only the left hemisphere that's being affected right now?
Maybe the right part of the body is the one reacting.
Perfect. So this video used to be up on YouTube, but then YouTube took it down. I don't know why. So here's the best video I've personally found for a partial seizure. I've actually incorporated it into my lectures. You're watching a lecture, recording of a lecture. Sorry. But this kid here is having a partial seizure. What do you guys notice? It's only on one side, right? So currently the patient's left side is convulsing. So therefore, which side of the brain is having this seizure?
Right side.
I'll play this out a little bit more just because it's kind of interesting here. The most terrifying thing about a partial seizure is that you're awake. Half of your brain is fine. Half of your brain is conscious. You are still processing this. So it's not particularly dangerous, but it's just scary that you all of a sudden lose control over half of your body. Okay, so kids going through this, again, it's just the anxiety, it's just the fear. Again, you know how ruthless kids can be in school. Like, oh, there goes twitching Tim, or something like that, right? So it's just, again, not dangerous, but just more scary. You see this poor kid's drooling, he can't help it. So you see the dad's actually doing perfect right now. We are not fully restraining the patient, we're just holding them until they come out of it. Okay, so kind of wholesome. So that is a partial seizure. Okay. Now, most seizures are typically generalized, so the entire brain's going crazy. A type of seizure there is an absence seizure. They literally look like they're staring into space. Okay. Take, for example, an absence seizure. I might just start looking into the corner, staring into nowhere, and you see drool coming down my face. I'm not shaking, but I'm also not responding. Like if you're calling my name, you're not there for me, okay? Now, the tonic-clonic or the grand mal or convulsion. Okay, that's the one that people typically think of when it comes to seizures. It's that shaking, okay? In a tonic-clonic, grand mal, or a convulsion, in terms of first aid, so a little bit of a horror story here. This is meant to inspire you guys. Coworker of mine that I used to work with, she went to Chipotle for lunch. Cool, no big. She's like maybe third in line. It's lunch hour. There's a whole line behind her. The person in front of her actually just collapses right in front of her, just collapses to the ground and goes into a full convulsive seizure, shaking on the ground. Now, what ended up happening was the Chipotle staff never stopped taking orders, despite somebody convulsing in the front of the line. The people behind them were physically stepping over this shaking person to place their fucking orders. Yeah, there's problems with that. So let's talk a little bit about first aid. If someone starts going into a convulsive seizure, what's the best thing that we can do?
Move everything out of the way and time it.
Yeah, you definitely want to like ease them as they're falling. If you can, try to protect their head. If it's like a 350-pound dude, don't try to catch them, okay? But you try to like make sure their head doesn't slap into something. Move the tables, move the chairs, whatever, and you time it. Now you don't restrain them to the ground, okay? Another thing is, I don't know why, but back in the day, they used to say, you take 3 of your fingers and you put it in their mouth to keep them from biting off their tongue. Why is that a bad idea?
Because they'll bite off your fingers.
Shaka bra. Yeah, don't do that. Don't put anything in their mouth. Don't put your fingers in somebody else's mouth. That's weird. Okay. So once they're done convulsing, again, you've timed it. What you want to do is you want to roll them over onto their side. You guys ever see those like alcohol poisoning PSAs? You want to put them in the recovery position, just so that way they can get the spit and vomit out. Okay. Now at that point, it's up to them if they want to call an ambulance or not. I've had a student actually seize in class for the first time. That's why I kind of take it pretty personal. Okay. So just, hey guys, if somebody's convulsing, like it's not actually scary. I don't know why the general populace is just terrified of these things. It's cool. It's chill. But I encourage you guys, please, please be the one that's helpful. Don't just stand and stare and be a bystander, okay? Epileptic, again, just unknown. Okay. All right, so these things can cause seizures. You don't need to memorize this. I just need you to know the different types of seizures. Cerebral hemodynamics, we're actually going to get into on Monday. So we're going to go like, Okay. Traumatic brain injuries, we're going to keep this one very, very superficial, very brief. Okay. There's 2 types of TBIs, focal or local, and then diffuse. Anybody want to guess which one's more common, local or general, focal or diffuse?
Diffused?
Mm-hmm. Nice. It's more common. Okay. And I'll explain why. So in a focal brain injury, if there's an open brain injury, i.e. something has penetrated the skull, if the skull becomes compromised, people typically lose consciousness, typically. Okay. If the skull remains intact, this can cause a contusion. Anybody familiar with the term contusion?
Isn't it a bruise?
It's a bruise on your brain. Okay, so I'm going to show you what a contusion looks like here, but again, closed injury, it can cause a contusion. That's really the only point you need to worry about. Okay, so take for example, here's a wall. Here's my face meeting that wall. What do you guys notice happens to my brain? If I just rail my head into the wall, what happens to my brain?
It also hits the front of your skull.
It slides forward and smashes the front of the skull. After smacking my head into the wall, I realize this is a terrible decision, and I recoil back. Now, which part of my brain is getting squished?
Back of your brain.
Yeah, the posterior. So you see what I'm saying is the reason why diffuse is more common than local is because the brain is rattling inside of the skull. Multiple areas are going to be affected from a single hit. Okay. So again, just showing, hey, the brain's rattling around in there. Okay, so you don't need to memorize anything from these slides here, just showing it can happen in the anterior posterior plane. It can happen laterally. FYI, rotation is the worst. Rotation is the worst. It just causes the most axonal shearing, causes the most trauma to the neurons. Really, you really shouldn't see rotational trauma. The only place that you will actually see rotational trauma a lot of is in motorcycle accidents. Okay. So contusions, you got brain bruising, so i.e. leaking blood vessels. Okay, 3 different types of contusions or hematomas. So just reiterating, contusion means bruise. Hematoma also means bruise. Okay, so 3 different ways to say, so let me say bruise is a contusion, which is also a hematoma. 3 ways to say the same thing. So starting with epidural, using a little bit of Latin here, epidural, what does that mean? The center, you're the epitome. Epi means top or above. Dural refers to what?
Dura mater.
Perfect. Above the dura mater. So an epidural hematoma is a collection of blood. It's a bruise above the dura mater. Typically with an epidural hematoma, so let me say typically, the skull is compromised. So i.e. the skull is broken, we are leaking. Okay. So therefore, what does subdural hematoma, what does that mean?
Below the dura?
Below the dura mater. Okay. Usually the skull is still intact. Okay. Alcoholics seem to be at risk for these too. Again, it's just a risk. Alcoholics at increased risk. Why? Why would an alcoholic be at risk for a brain injury? That's weird.
Alcohol thins the blood.
Alcohol definitely thins the blood. And
Also,
how's my balance?
That's what I was just going to say. They're also at more increased risk of falling because of intoxication.
Beautiful. Beautiful. Alcohol increases risks for your subdural because of those factors. Absolutely. And then finally, you have an intracerebral hematoma. What does intracerebral translate to?
Within the cerebrum.
Mm-hmm. Within, I'm going to say within the brain, just going to keep it easier. Okay. So be careful. All three of these are intracranial. Intercranial. All three of these are intercranial. What does intercranial mean?
Inside the cranium, the head.
Inside the skull, yeah. So be careful here. A lot of students mix up intercranial with intercerebral, two different things. All three of them, hey, look, I'm bleeding into my skull. Only one of them means I'm bleeding into my brain. Just be careful with that wording there. So I'm going to ask you a classic med school question. 3 patients get brought into the emergency room, one with an epidural hematoma, one with a subdural hematoma, and one with an intracerebral hematoma. Which patient do you see first?
Intracerebral.
Intracerebral. Alexis, you vote same way?
Yes.
Anyone? Yes, yes. Greg's with you. If you guys check out the intracerebral first, your subdural hematoma is going to die. Okay, why? So let me say subdural is the most time sensitive. Most time sensitive. Okay, subdural hematomas, death results in 6 to 8 hours. With an intracerebral, death results in 24 hours. So let me be clear. Both of them are bad. Okay. Subdural is just going to kill a person faster. Okay. Which one's going to be the most difficult to treat? Epidural, subdural, or intracerebral?
Be the intracerebral because it's within the brain.
Exactly. That is going to be the most difficult to fix. I mean, like, let's think about this. How are you going to fix a bleed into the brain, right? Do you like take it out of the skull and rinse it in the sink and then pop it back in? If you're bleeding into your brain, we have to just really rely on the body, like the microglia, to clear up those excess blood cells, and that can take forever. Therefore, sorry, go ahead.
Why is the subdural hematoma most time sensitive?
Great question. I promise to get back to it. There's a picture coming up that just makes more sense than me hand waving. Therefore, which one's the easiest to treat?
Epidural.
Epidural. It's the easiest. So going to that question here, I'm going to come back to this one here. All right, so here's a skull with all three going on. It's pretty bad. Notice with your epidural, my skull has been fractured. Okay, so blood is going to leak out, no problem. Subdural, I'm bleeding in one area. I'm bleeding in one area. Intracerebral is going to be applying pressure evenly throughout my entire brain. So, question, would you rather lay down on a single nail or a bed of nails?
Bed of nails.
Bed of nails, because with the intracerebral, we have pressure being applied throughout the entire brain. So this is why death still results, but it's like 24 hours. With a subdural hematoma, I am going to be pushing down on one part of my brain very significantly. Do you have to worry about pressure buildup with an epidural hematoma?
No, because it's going to leak out.
Exactly. Honestly, you just slap a Band-Aid on there, it's fine. A little bit more complicated than that, but in essence, okay. So kind of going back to it here. Subdural is the most time sensitive because we have pressure build up on one area. Versus intracerebral, we have pressure dispersed over the entire brain. And what we were mentioning, epidural is the easiest to treat because there's no pressure buildup. So Alexis, does that hopefully answer the question there?
Yeah, thank you.
Yeah. So I don't know. I mean, like subdural is kind of dangerous, right? Wouldn't you say? Like you got time on your time's a limiting factor. How do we treat subdural hematomas?
Release the pressure.
How do we release the pressure?
Open a hole.
Yep. Enter power tools. We will physically drill a hole or do a shunt just to relieve pressure. Okay, that's why, again, the intercerebral is harder to treat than the subdural. Subdural, you just poke a hole. All right, this slide, the diffuse brain injury, you can just X through it. Concussions. So with concussions, you can have a variety of different symptoms. You don't need to memorize this because it depends on which part of your brain gets hit. Okay, it just depends on which part of your brain gets hit, then you can have different symptoms. Point to take away here, you do not need to lose consciousness to be concussed. Concussions are by far the most common form of a TBI. Two types of concussions. You'll have a mild concussion, where again, you don't have to lose consciousness, versus a classical concussion, where somebody loses consciousness for less than 6 hours. Now, I don't know who came up with the timeline. Okay, if I see some poor kid get hit so hard that they're knocked out, that they have lost consciousness, I'm freaking out after 10 minutes. Okay, I'm not gonna sit there like, oh, well, 3 hours, we got 3 more to go. Like, so what I'm saying is don't be fixated on that less than 6 hours bit, okay? That's kind of extreme for me. All right, cool. So now we are going to enter the third part of lecture. And yeah, we'll wrap it up. Okay, so you guys cool if we do a little bit of a shorter break here? Okay, let's say like 10:20. We'll pick back up again. Okay, let me know if you have questions or if you need me to go back to any slides or anything like that.
Yeah, that's also a nice knife. I think probably coming in about the same. It's a little bit shorter. This one's probably about 8 inches overall. So yeah, we have 3 really, maybe we should zoom in on these. Can we do that? Yeah, how about like that? There we go. 3 really nice looking models from We. I will link these if I can. I don't know if they're all available. Obviously, special edition versions of things may or may not be available, probably not. But the standard versions of these knives, if they are available, I will link them right down below. These are all super interesting, and I'm definitely happy that you sent me more than just the one that we discussed. Thank you for that. I appreciate that. Well, I think that's going to be pretty much it today. Obviously, this is not a review. This is just an unboxing of first impressions.
My bad. I totally forgot that I was still sharing audio. All right. So last part here. Spinal cord injuries, kind of straightforward here. So I'm going to say like you can X out this slide here, no problem. For this slide, be just familiar with the terminology. So if I use it in a question, like quadriplegia, 4 limbs, paralyzed, this is usually the result, so I'm going to say usually secondary to trauma. Okay. Paraplegia, again, is usually secondary to trauma. What about hemiplegia? Like if somebody's lost weakness or has paralysis on one side of their body, what's the usual cause of that?
CVA.
Yeah. Usually secondary to a CVA or a stroke. Perfect. Herniated discs suck, but don't worry about it. So I'm just showing you a picture of a herniated disc. Again, don't worry about it. Okay, now talking about CVAs. So the reason why I keep calling them CVAs, cerebral vascular accident. Sorry. CVA. Sit. Sit.
You should put your dog up to the camera so we can see.
You want to see the badly behaved whiskey? She's a short one.
She's super cute.
Yeah, especially when she's following the rules. Whiskey, please. Down. Down.
Oh, Greg has a cute dog too.
I know, dude. I saw Greg was like carrying 3 dogs around, dude. That guy's the dog whisperer over there.
We have 3 dogs, yes.
That's so cute. Sorry. CVAs, strokes, are the most frequent neurological disorder. Okay. So there are 2 types of strokes, 2 types of CVAs. Let's see, types. Ischemic is one type. So ischemic can be ischemic thrombotic. So think of it like as 1A. Embolic is 1B. Okay. Or it can be hemorrhagic. Then let me say both are associated with hypoperfusion. Okay. Sorry. So tracing back, I know I mentioned this a while ago. Okay, so just refreshing. If we see decreased perfusion, good. That's called ischemia. So lack of blood flow. What does lack of blood flow lead to?
Lack of oxygen.
And
What do we
tissue.
call that? What do we call low O2?
Hypoxia.
Yeah. Hypoxia, which again, if unresolved, will lead to
Cell death.
cell death. And what's the term for cell death?
Dysplasia.
Necrosis.
Are there
Necrosis. Perfect. Necrosis. Come here. No. Okay. So ischemia, hypoxia, necrosis, I kid you not, you will hear it every single lecture throughout. This is by far the most important pathway in all of patho. Legit, I'm not kidding. Every time, like I get a tattoo for every like momentous part of my life. When I finish nursing school, that's the tattoo I'm gonna get. Okay. Ischemia, hypoxia, necrosis. You're gonna be chanting it so much that it's gonna seem like you're in a cult. So here we're seeing the two different types of strokes. In this case here, this is a hemorrhagic stroke. So this is that 1B. Okay. Here I've ruptured a blood vessel, so I am bleeding. Okay. All of that blood is going to clot. If this turns into a giant blood clot, how much more blood can get through? Oh, sorry. You're probably right, Lita. Yeah, sorry. Hemorrhagic is type 2. My bad. Sorry. Thank you. So how much blood can get through if this turns into a giant clot? Not much, right? Ischemia, hypoxia, necrosis. Now the ischemic strokes, that was the two types, okay? So let me say one over here. Okay, so for A, now I'm just double checking, is a thrombotic. So that means a blood clot has formed there. So maybe I shouldn't use green. Use pink. Does that show up a little bit better? Does the pink show up a little bit better on your guys' screen? Okay, so with a thrombotic, that means your blood clot has formed there and has gotten stuck there. Therefore, it is stationary. Okay. Again, the ischemia, hypoxia, and necrosis applies. The second type was embolic. Embolic means traveling. Okay, so if I had a blood clot that may be formed in the leg and then traveled up to the brain and then got stuck, that is an embolic ischemic stroke. Okay, so that's kind of the two differences there. So just kind of giving it some words. Your ischemic stroke type, like first type. Okay. So 1A. Your thrombotic stroke, do yourselves a favor. Anytime you see thrombotic, I want you to think stationary. Okay, it formed in the arteries. Versus embolic, that means traveling. Okay, so it traveled outside of the brain, it formed outside of the brain and traveled to the brain. Okay, now one of these subpoints here, the transient ischemic attack. So what happens is I have stroke-like symptoms for usually less than an hour. So take, for example, I'm on camera right now, I'm talking to you. If all of a sudden I start slurring my words and then half of my face starts drooping, you freak out, you call 911, you realize you have no idea where I live. But then I get to the hospital and I regain speech, I regain facial symmetry. What happened?
A mini stroke.
Mm-hmm. So what happens in a mini stroke?
Is there a clot that's like temporarily stuck and then moves on?
So I had a passing blood clot. Exactly. So in a mini stroke or a TIA, I had a blood clot, it got stuck, I had my symptoms. However, that clot ended up passing on restored blood flow, no more ischemia, no hypoxia, no necrosis. So, question, am I safe? Why not?
Because usually this is like a sign that a big one's coming.
Awesome. So the way I kind of think of this, you dodged the bullet. Question is, where's that bullet? Is he going to get lodged somewhere else? Is there a bigger clot on the way? Who knows? So just heads up, TIAs are still medical emergencies. Okay. Again, all of them are associated with hypoperfusion, i.e. ischemia, hypoxia, necrosis. Okay. Hemorrhagic stroke. So that was the other type there. Hypertension is the primary cause. So high blood pressure. So this can be the result of a ruptured aneurysm. Okay, so let's kind of define an aneurysm. An aneurysm is going to be a distended blood vessel. Usually an artery. So I want you to think of a water balloon. As you're filling the water balloon, it gets bigger and bigger, right? Towards the end, do you have that moment of like, should I put any more in? Okay. And if you overfill this water balloon, it's going to rupture. That's what kind of happens here. So hypertension, your blood pressure is so high, it's causing your arteries to distend and dilate out. Okay. Now, we typically think of aneurysms happening in the brain, and they can happen in the brain. What are your symptoms of an aneurysm? What are your symptoms of this distended blood vessel?
Have like a headache, right?
If you're lucky.
Okay, sure.
Yeah, I was gonna say usually aren't there none? Usually they just kind of pop.
Typically asymptomatic. You are lucky if you get symptoms. If you get symptoms that, hopefully you go and seek medical attention, you can get it remedied. But, sorry, asymptomatic. Some people will report headache. Some people will report blindness. Some people will vomit. Those are the lucky ones, okay? So right now, do you know if you're developing an aneurysm? No, this is kind of like that nightmare situation where somebody gets into a minor fender bender, like you get rear-ended, head snaps back, you get whiplash, and they had an aneurysm. Snapping back ruptures the aneurysm, you're bleeding into your brain, you're dead before the paramedics get there. It's like a nightmare situation. So these are different types of aneurysms. You don't need to memorize them. Just saying, hey, look, this blood vessel is severely distended. What caused that? The high pressure. Okay. All right. So talking about headaches, very, very brief, nothing too crazy. You need to know maybe one or two things, not much. Migraines. Migraines can last anywhere between 4 hours to 4 days. Anybody in this class get migraines? Okay, we got a couple. Okay. They typically affect women. Okay. Now, if I asked all of you guys, what do your migraines feel like? Y'all are going to come up with different descriptions. And this is what makes migraines kind of difficult because everybody's migraine is different. Okay. Some have throbbing, some have vomiting, some have light sensitivity, some of them sound. It can vary quite a bit. So just understand migraines can last anywhere between 4 hours to 4 days, and they typically affect women. Okay, these are different things that can set off migraines, but because of this huge variance, don't worry about it. Okay, cluster headaches. Has anybody ever heard of cluster headaches? Got one or two? Yeah. Cluster headaches have the fun nickname of being known as suicide headaches. Okay. The reason why they have that fun name, people have actually committed suicide over the pain that these things can cause. Cluster headaches are no joke. Okay. Personally, I actually lived with a dude back in grad school who used to have cluster headaches. He'd get them maybe like once or twice a month. But once or twice a month, we would wake up 3, 4 in the morning of him just gutturally screaming into the floor in the fetal position. Okay. This typically affects men. The way he would describe his pain is, imagine you had several needles being pushed into your eyeball from behind. It's like pulling and pushing your eyeball out of your skull. That's the way he would describe it.
Do like NSAIDs or any kind of pain relievers like take that away?
He said no, but I imagine in some cases probably, but usually from my understanding of it, no. Unfortunately, there's not really any over-the-counter treatments for cluster headaches. What has been on the horizon? Microdosing. People have been microdosing LSD and psilocybin, magic mushrooms. When you microdose, it's such a tiny amount, it's not enough to start tripping, okay? It's just a tiny amount to have a positive effect, and that seems to actually help prevent the onset of cluster headaches and migraines. So who knows, you might be giving out some magic mushrooms or LSD to your patients in the future. I know Boulder's getting on it. Tension headaches are by far the most common. I personally get these all the time. Can happen male or female. It's basically, it feels like a tight band is the best way I can describe it. It feels like I pulled a muscle in the back of my neck. I get these all the time when I am over caffeinated and dehydrated, which is all the time. Okay. So a question for you then, which headache has the worst kind of pain? Migraines, cluster, or tension headaches?
Subjective.
Yes. Pain is ultimately subjective. Who's to say that person's cluster headaches are worse than another person's migraines? You can't. So perfect. That's the key point here. Pain is ultimately subjective. Okay. All right. So this we're going to skip. I wanted to make sure we had some time for here. Now we're talking about neurodegenerative disorders. So for these ones here, what I would recommend is definitely know kind of symptoms, cause, and if there's a treatment. Some of them know. So, and some of them we don't know the cause. So just as a heads up. Okay. But yeah, these ones here, I would say if you like flashcards, go for it. That's really kind of, this is your time to shine. Okay. So Alzheimer's. Alzheimer's, this one's personally near and dear to me because it runs in my family. I actually have a high likelihood of having Alzheimer's. With my lack of short-term memory, it might have already happened. Not entirely sure yet. Okay. But Alzheimer's is a type of dementia. Okay, remember how I mentioned dementia is this loss of multiple cognitive processes? Alzheimer's is a type of dementia. Okay, there are 3 symptoms that indicate Alzheimer's. First up is tau tangles. Tau tangles, these are just basically misfolded proteins. Misfolded proteins. Next up is amyloid plaques. So amyloid plaques, these are basically pockets of necrosis. So if we looked in this person's brain with Alzheimer's, we would see this tangled mess of proteins and parts of the brain actually necrosing. The third thing we would see, cerebral atrophy. What does cerebral atrophy mean?
The loss of cerebral tissue.
The brain's getting smaller. Perfect. Okay. Now, this is a current theory of Alzheimer's. There's multiple theories. So even one of them that I'm actually particularly interested in, Alzheimer's might be type 3 diabetes. So that's a fun fact. Okay, so 3 symptoms: tau tangles, amyloid plaques, and cerebral atrophy. Okay. Now, most people think Alzheimer's, when they think of Alzheimer's, they think of forgetfulness. Yes, this happens, but does it have to happen? It's any cognitive processes, okay? So emotionally being upset, confusion, lack of awareness, forgetfulness, etc. Again, it's a type of dementia. So is forgetfulness a signature symptom? Is forgetfulness only associated with Alzheimer's disease? No. So just heads up, this is not a signature symptom. Okay. So taking a look here, this is a healthy brain. This is a brain on Alzheimer's. If you notice, one of them is looking a little scrawny. That's your cerebral atrophy. Okay. Your tau tangles are these clumps of misfolded proteins, and these amyloid plaques, these pockets of necrosis, get bigger. So again, just reemphasizing, dementia, Alzheimer's, irreversible. Is there a treatment? Not yet. Okay, so remember how I said treatment, question mark? Sometimes there is no treatment. Although I don't know if anyone keeps up with the news, but there's this company that supposedly released a cure for Alzheimer's disease. 1 month of this medication, I believe it's 1 month or 1 year, either way, it's ridiculous, costs $50,000. And the data that they use to produce this drug is faulty. They claim that is a cure for Alzheimer's in mice, but haven't done it on people. Dude, there's some weird stuff going on. So here's an actual photograph of amyloid plaques and tau tangles. Now, can we just cut off a slice of somebody's brain and take a look underneath the microscope? Not really. So the only way to actually have a full, accurate diagnosis of Alzheimer's is post-mortem, i.e., you got to take my brain out when I'm dead. We can guess, basically, that they have Alzheimer's because of the symptoms, and we can actually see the brain shrinking. So, fun fact. Parkinson's. Okay. Now, Parkinson's is severe degeneration of the substantia nigra. If you remember the substantia nigra, that was for fine motor control. And the issue is you have less dopamine. So the way I remember this, dopamine is like when you smoke dope. Okay, I'm assuming that dope is weed. When somebody smokes a lot of weed, what kind of posture do they take on?
Slouched, like relaxed.
Yeah, exactly. They're slouched, they're relaxed, because dopamine causes relaxation. Therefore, acetylcholine causes contraction. Okay, so if this person has less dopamine, what are they unable to do?
Relax.
Relax. So try this. Set your pens down. Okay. I want you to extend your arms make two fists as tight as you can. Tighten your fists. You see the whites in your knuckles. Tighten your fist, your wrist, your elbows, and your shoulders. Just keep everything super tight. What happens to your hands? What happens to your arms?
Start to shake.
Ta-da. This is how I remember this. Parkinson's has this tremor. Because they're constantly contracting, they have this rigidity. Bradykinesia, slow movement. Okay, so that's again how I remember the functions of dopamine versus acetylcholine. In Parkinson's, no dopamine, they can only contract. Okay. Postural disturbances can kind of happen too, but I'm not really focusing on that. There can be some cognitive symptoms, but again, really the takeaway point, Parkinson's, you have this tremor, this rigidity because of a lack of dopamine. Dopamine is meant to inhibit, is supposed to help relax. Okay, so you have this lack of inhibition. Does that kind of make sense? There's a double negative there. Lack of inhibition. Okay, so this is actually kind of cool. This is helping people out with Parkinson's. I forgot I added this slide. So on the left, you see somebody with Parkinson's. What they're doing is, you know, basically a TENS unit. A TENS unit causes muscle contraction. This person is wearing an exoskeleton where it's a series of TENS units, and the electrodes actually contract to cancel out the signal from the brain. How friggin' cool is that? We send patients home with TENS units all the time. Y'all, this is a crazy time to be a nurse right now. I don't know if you've noticed, there's a few things going on with technology, but that can be so life-changing. One of the things that patients with Parkinson's will talk about is how you lose autonomy. You can't dress yourself, you can't feed yourself, you can't go to the bathroom. Things that you and I take for granted every day, they struggle with.
He looks so happy just to touch his nose in this video.
Yeah, exactly. Like, and just giving somebody a slice of normalcy, like, how amazing could that be? Like, how empowering can that be for a person, right? So that's kind of cool. So ALS, this neurodegeneration of upper and lower motor neurons. Generally, what this is getting at is we will see ascending paralysis. Okay, so first the toes will become paralyzed, and then below the ankle, above the ankle, below the knee, so on and so forth. It keeps rising throughout the body. There is an unknown etiology, which means unknown cause. Okay, so this is one of the ones where we don't know the cause. What kind of sucks about ALS is that a person will retain normal intellectual and sensory function. So, case in point, I kind of think of one of my personal heroes, Stephen Hawking. Anyone? Hopefully you've heard of him. Yeah. Stephen Hawking had ALS. Was his intelligence intact? Yeah, it kind of was. I still don't understand anything about his book, like one of his books. I tried reading it, completely lost. Okay, like the guy was fucking brilliant, but trapped in a chair. Okay, usually fatal within 3 years because of respiratory failure. So I want you to imagine you have this ascending paralysis. As it's ascending, what muscle is going to become paralyzed? That's going to prevent you from breathing.
Your diaphragm.
Diaphragm, perfect. the diaphragm becomes paralyzed. So the fact that Stephen Hawking lived for almost 30 years with ALS, he's the only case in recorded history. They're actually theorizing that he had a different form of ALS and that it's more of a spectrum, kind of like autism, than what we previously thought.
I was going to ask, aren't there different types of ALS? My friend's dad has ALS and he's been living for like 15 years with it.
Yeah, and that's one of the nice things is like, exactly. It's being treated now more like a spectrum rather than like, boom, you have ALS. Great. Okay. Now, multiple sclerosis. Multiple sclerosis is this demyelination of the central nervous system. Central nervous system. So we're talking about the brain and the spinal cord. It is autoimmune of unknown origin, i.e., which hypersensitivity is this?
2.
Nice. Type 2 hypersensitivity. Okay, and now we know if you receive damage in your central nervous system, are you likely to regenerate? No. Okay. Loss of myelin disrupts nerve conduction with subsequent death of neurons and brain atrophy. It is irreversible. Okay. Depending on what's demyelinating, different cranial nerves, parts of your spinal cord, etc., you can have different symptoms. Really, I just want you to know type 2 hypersensitivity, central nervous system, irreversible. So what could be a treatment for multiple sclerosis?
Immunosuppression.
We can do immunosuppressants, and that's one of the things we'll do to slow down multiple sclerosis. Very good. Okay. So, hey, your myelin sheath's disintegrating. Guillain-Barré. Guillain-Barré is the demyelination of the peripheral nervous system. So what do you think the big difference between multiple sclerosis and Guillain-Barré would be?
Guillain-Barré could be regenerative, where multiple sclerosis could not.
Perfect. Guillain-Barré can be reversible. You can regenerate. Perfect, perfect. Again, it's usually a type 2 hypersensitivity. Don't need to know this subpoint here. Okay, and that's why we can see recovery. You can see recovery because it's reversible. Just depends on which nerves are gone, how bad it is. Sometimes the nerves don't completely grow back. Sometimes they grow back and they're super sensitive. But generally, you can see regeneration with Guillain-Barré.
Is this what sometimes people get if they have a bad reaction to like the flu vaccine? Or am I way off?
I don't know.
There's like always a checklist, and there's something that starts with G and B that you have to say.
That they check off on in primary care offices for like flu vaccines. So.
Oh, so like this is a disqualifier, right? Like if you have Guillain-Barré, you shouldn't get this vaccine.
Yeah.
Okay. Thank you, Megan. Yeah, I don't know. I don't know why. My guess is maybe your body might misinterpret that vaccine, and that might cause an outbreak of Guillain-Barré where your nerves will start demyelinating, and that's no fun.
So is the treatment for that an immunosuppressant then too, or do you just wait for the body to hopefully heal itself?
Generally, I haven't seen patients with on immunosuppressants for Guillain-Barré because you have the reversibility, and it happens more in waves. With multiple sclerosis, it's this constant eating away. With Guillain-Barré, it kind of has flare-ups, if you will. So generally, you don't need to have a treatment for Guillain-Barré just because it'll fix itself. Great question. All right, and I believe the last one, myasthenia gravis. So with myasthenia gravis, notice I am making an IgG antibody against my acetylcholine receptors. So here again, I am targeting and destroying my own tissue. What hypersensitivity is this? It's going to be a type 2. Okay. Now let's kind of think about this. If I attack my acetylcholine receptors, if I have no acetylcholine receptors, that means I have no acetylcholine response. Now, what did acetylcholine do? It's the opposite of dopamine.
It contracts your muscles.
So therefore, if I have no receptors, no response, I have no contraction. So without even having to know whatever myasthenia gravis is, what kind of symptoms would a nurse anticipate?
Probably like an irregular heart rate.
Yeah, maybe irregular heart rate, for sure, for sure. What about
They're generally
skeletal
like pretty flaccid and like relaxed. Like their muscles.
weakness? Yeah, fatigue. Okay, absolutely. Okay. The big one, the big difficulty, or the big issue here is difficulty chewing, possibly swallowing. So these people here can be at risk for choking. Okay. And that, as they say, is that. So that is Neuropath. Again, it's seems long, but it's a bunch of like weirdly disjointed topics, things from like fever to hyperthermia to neurodegenerative disorders. Again, it's still kind of pretty superficial throughout. Let me give you guys a heads up. Monday's lecture, pH, fluid, and electrolytes. You've heard me whisper about it. It is one of the lectures that people typically struggle with. Okay, just because there's a little bit of chemistry, there's a little bit of physics involved. Not much, but a little bit. Monday, bring coffee. Be ready, yeah. I like the stuff. I think it's cool, but then again, that's me. Yeah. So with that, let me know if you guys have any questions. Office hours, or shoot me an email. Yeah, I hope all of you kids have a great weekend. Stay safe out there. Greg, I need just next time I see you, I need you curling a dog in each arm, okay? All right, everyone have a good weekend, yeah?